Hi guys, this is Dr. Patil here, and today we will be discussing about gout and other crystal associated arthropathies. Now we all recognize gout as a very important topic for NEET super specialty because everything related to gout has been asked in one or the other form of MCQs in the past. But we have to also recognize an emerging template of MCQs where they might ask you to compare between gout or pseudo gout, or you have to finally conclude the particular story or clinical picture whether it is a case of gout or pseudo gout. So be it clinical features, be it pathophysiological process, be it diagnostic approach, or be it imaging modalities. All of these are important in terms of comparison between gout and pseudo gout. So as we go along with the discussion of the topic, I want your attention on the key points which actually help us to distinguish between gout and pseudo gout, right? So gout is definitely a very important topic for us, and apart from gout, pseudo gout is the next most important topic. Pseudo gout, we also call it as calcium pyrophosphate deposition disease, and today we will also be spending maybe 4 or 5 minutes learning key points about basic calcium phosphate or calcium apatite deposition disease and calcium oxalate deposition disease. Okay, now to start with gout, we all know that gout is a condition characterized by often inflammatory arthritis in the acute form, or in chronic form what we call as tophaceous gout, right? In both these cases there is deposition of monosodium urate crystals. So that means patient has to have increased uric acid in the body, right? So the uric acid levels at the time of presentation in the form of acute gout may be normal or decreased, but generally speaking these patients have increased serum uric acid levels, right? So first we have to understand causes for hyperuricemia. Okay, now to understand the causes for hyperuricemia, we have to understand the purine metabolism, because we all know the uric acid is the final end product of purine metabolism. So purines in the body exist mainly in two forms, what we call as adenine and guanine, right? Adenine and guanine. So body has a rich purine pool. Okay, and now these adenine and guanine are our building blocks of DNA and RNA. So they are important components of our DNA and RNA, and they are also component of our energy currency of the cell, that is ATP and our GTP, and its intermediates like GDP and GMP and ADP and AMP. So every time there is a active cell metabolism going on, lot of these molecules will be utilized for various cell metabolic processes, right? ATP will be used up, GTP will be used up, then DNA and RNA will be degraded and resynthesized. So there will be a lot of turnover of adenine and guanine. Now once the adenine and guanine are formed, particularly the major source of adenine and guanine is basically coming from the purine nucleotide itself, that means from the DNA and RNA itself, right? Now these molecules can be reused, they can go back to the purine pool and they can be reused for synthesis of newer DNA, RNA molecules or ATP and GTP molecules. But the excess amount of adenine and guanine that is now produced because of the degradation of DNA and RNA has to be eliminated. The usual route of elimination is through renal, right? Through renal, that is like that accounts for around 70-80% of the elimination, and remaining 20-30% of the elimination occurs from the GIT or through the gut. But they are not directly eliminated. Particularly when we talk about renal elimination, they are not directly eliminated. So what is the mode of elimination? These molecules have to be converted to uric acid, right? They have to be converted to uric acid and then they are eliminated from the body. That's how the uric acid comes into picture, right? So here is a flow chart that summarizes the purine metabolism. So let us talk about our building blocks, that is adenine and our guanine, right? So if you start with our adenine and guanine, you will notice that our guanine can be directly converted to a molecule called as xanthine. That is the just immediate precursor of uric acid, right? So this xanthine is converted to uric acid by an enzyme called xanthine oxidase. This is in fact a very important target for our pharmacotherapy of hyperuricemia and gout, right? Okay, and if you look at this adenine cannot be directly converted to xanthine, so it has to go through a complex steps to be converted to xanthine, right? So this adenine has to be converted to adenylate acid. Similarly, if it is a purine nucleotide, adenosine has to be converted to adenylate acid, that has to be converted to inosinic acid, and this inosinic acid actually also derives from glutamine and PRPP. Now inosinic acid then becomes inosine, hypoxanthine, xanthine, and then eventually uric acid. So there is a complex set of events involved in conversion of adenine to xanthine. Guanine can be directly converted to xanthine, right? Okay. Now there are 2 or 3 important enzymes that we have to recognize in this flowchart. Okay. Now the first enzyme we are talking about is phosphoribosyl pyrophosphate synthetase, PRPP synthetase. Okay, so this utilizes ribose 5-phosphate to convert it to phosphoribosyl pyrophosphate that combines with glutamine to form inosinic acid. Clear? Now this inosinic acid can become inosine, hypoxanthine, xanthine, and uric acid. So if there is any condition where there is PRPP synthetase activity is increased, what is the outcome? If the PRPP synthetase activity is increased, that means more inosinic acid is formed. Once the more inosinic acid is formed, eventually more uric acid is formed, right? So your PRPP synthesis activity, if it is increased, it can be associated with increased uric acid production, or in other words, hyperuricemia. Okay. Now the next thing we recognize here is another enzyme called as HGPRT, which is known as hypoxanthine guanine phosphoribosyl transferase, HGPRT or HGPRTase. Okay, where do we hear about it? We hear about it when we talk about a condition called as Lesch-Nyhan syndrome, right? We hear about this when we talk about a condition called as Lesch-Nyhan syndrome, where there is deficiency of HGPRTase activity. Now, whenever there is deficiency of HGPRTase activity, what can happen? Okay, so from the flowchart, you can notice that I have already told you this guanine and adenine can go back to the purine pool, and they can be utilized for production of the building blocks of, or the nucleotides for RNA and DNA. They can also be utilized for formation of AMP and thus eventually ATP, and GMP eventually GTP, right? Okay, so this guanine to guanylic acid conversion is done by this HGPRT. Then this hypoxanthine can also be converted to inosinic acid, and thus it can be used for formation of adenylic acid, thus adenosine, and then eventually ATP and its precursors, right? ADP and AMP. So this conversion of these purine bases back to the purine pool, that is done by HGPRTase. So if there is a HGPRTase deficiency, what is the outcome? Now there are 2 possible pathways. Right? When guanine and adenine are present in a cell, through HGPRTase they can go back to the purine pool, or they can enter this uric acid formation pool and then get eliminated in the form of uric acid, right? So if there is HGPRTase deficiency, right, if there is decreased activity of HGPRTase, then again patients can be associated with increased uric acid production or hyperuricemia, because there is only one outlet in that case. So this outlet is blocked. So all the guanine that is formed has to be converted to xanthine and eliminated in uric acid, and all the adenine that is formed has to be converted to xanthine only, because hypoxanthine will anyway be formed, that will not be converted back to inosinic acid. This pathway will be blocked. So hypoxanthine will eventually be converted to xanthine only, and thus uric acid, right? Clear? So we have learnt about 3 important enzymes. PRPP synthetase increased activity, increased uric acid production. HGPRTase decreased activity, increased uric acid production. And the third enzyme we spoke about was xanthine oxidase. So this we are using as a potential pharmacological target, right? If you block xanthine oxidase, then the whole pathway is arrested at xanthine, right? It is not getting converted to uric acid. So this way we can reduce plasma uric acid levels, right? Okay. Now this component of this purine metabolism pathway is not usually seen in humans, but in some lower primates and birds, they have additional enzyme called as uricase. So that converts uric acid. Uric acid is a toxic substance. So uric acid is converted to allantoin, which is less toxic substance and which is much readily eliminated by renal excretion, right? So this conversion to allantoin is only seen in lower primates, not seen in humans, seen in some lower primates in monkeys, and seen in birds. Okay. Now this can also be used as a potential target. Like we don't have this uricase, but we can give uricase to a human who has elevated uric acid, or like you can give a recombinant uric acid, what we call as rasburicase, right? Where do we talk about it? We talk about it when we talk about tumor lysis syndrome, right? So we can try to convert this uric acid to allantoin, which is a less toxic substance, which has a lesser tendency to precipitate in joint spaces. Clear? Okay, now uric acid, we have learnt about one drug, that is rasburicase. But the problem with this, like generally we talk about raspberry case when we talk about tumor lysis syndrome, because it's a very short acting. So when you have an acute rise in uric acid levels, maybe it is useful. But when you're talking about a patient with chronic hyperuricemia, this is not that useful because it's very short acting. So it needs to be given as an infusion, or it needs to be given at multiple frequent dosing. So that is not practically possible. So we have found a hack. We have created another drug called as pegloticase. Pegloticase, which is again a uricase, recombinant uricase, which is very long acting, right? It is a pegylated compound. So whenever polyethylene glycol molecules are attached to something, they become long acting. So this is a long acting uricase that can convert the uric acid to allantoin. So this is useful in patients with chronic gout. Clear? Pegloticase can be practically used in patients with chronic gout. Okay. Now, one important point we have to understand is hyperuricemia is not practically does not mean gout. Gout and hyperuricemia are two separate entities. Gout is where there is evidence of deposition of these uric acid crystals in joint spaces, right? Then we call it as gout. So whether it is acute presentation or chronic, that is secondary. And sometimes these uric acid crystals can be deposited in kidneys. So that is also a renal manifestation. But we have to understand that less than 10% of the patients who have hyperuricemia, right? Less than 10% of the patients with hyperuricemia actually present with gout. So that means more than 90% of the patients with hyperuricemia may remain asymptomatic, right? Okay. So if you have hyperuricemia and if you're asymptomatic, is that a safe zone? The answer is absolutely no, because having hyperuricemia is always a risk factor for gout. So you may not have gout today, but you can present with gout tomorrow. That is first point we have to address. The second thing is uric acid, I have been repeatedly telling, is a toxic substance. Allantoin, we are talking about less toxic substance. So why uric acid is toxic substance? Apart from crystallizing and getting deposited in tissues, it is also associated with various other metabolic abnormalities. What it can cause? At the level of kidney, it can cause what we call as urate nephropathy, right? We call it as urate nephropathy, where it gets deposited in the interstitium of the kidney, right? So urate nephropathy is a renal interstitial disease. Okay, that is one thing it can cause. The second thing it can cause is what we also know as acute tubular necrosis. So this acute tubular necrosis is because of the precipitation of uric acid crystals in the renal tubules. This we typically encounter in patients with tumor lysis syndrome, right? Not routinely encountered in gout patients. Gout patients typically we see urate nephropathy, but in patients with tumor lysis syndrome, where there is steep sudden rise in uric acid levels, they can precipitate in renal tubules, causing acute tubular necrosis. Then apart from that, there is increased risk of formation of uric acid stones, right? Uric acid stones. These are the renal manifestations, but the renal manifestations are not restricted to only these. Uric acid can induce oxidative stress on the kidney cells. It can activate renin-aldosterone angiotensin system. So RAS activation can be done. Then it is also associated with development of renal arteriolar disease. It can also cause interstitial macrophage and T cell infiltration, particularly when there is urate nephropathy. It can cause renal vasoconstriction and ischemia. So there is a risk of renal injury even if there is no gouty manifestations. Clear? That is one end. Second thing, today we all recognize gout as an important risk factor for patients to develop hypertension, and thus it is also a risk factor for CV events, or what we call as STEMI and STEMI. It is increasing the risk of coronary vascular events. It is also increasing the risk of stroke. Okay, all these are proven things. Hypertension, CV events and stroke risk is proven thing in patients with hyperuricemia, with or without gout, right? Why is it occurring so? Because uric acid can inhibit nitric oxide synthesis. Okay, then it can also induce endothelial dysfunction, and obviously it stimulates RAS. So there is a hypertension, CV event and stroke risk in patients with hyperuricemia. Clear? Okay. Now let us address what we call as hyperuricemia, right? So what is the normal uric acid levels? So the normal uric acid levels are usually in the range of 4 to 6 milligrams per deciliter. This is the normal uric acid levels. Now these normal uric acid levels in humans are slightly higher than the lower species. The lower species have uric acid levels lesser than 2 milligrams per deciliter, but when we talk about humans and some higher primates, we see that the uric acid levels is slightly higher. Okay. Now, when do we call it as hyperuricemia? Hyperuricemia is defined differently in males and in females. Hyperuricemia is defined differently in males and females, right? So, if we talk about males, generally serum uric acid levels greater than 7 milligrams per deciliter, or for females, the serum uric acid levels greater than 6 milligrams per deciliter, greater than 6 milligrams per deciliter can be considered as hyperuricemia. Okay. One key point I want you to note is, like, some authorities for males also mention 6.8 milligrams per deciliter as the cutoff to call it as hyperuricemia. Right? 6.8 to 7 for males, 6 for females can be considered as hyperuricemia. Clear? Okay. Now, why this particular 6.8 cutoff? Because when serum uric acid levels are more than 6.8 milligrams per deciliter, right, at this point of time, the uric acid starts crystallizing. That means the circulation is supersaturated and the uric acid starts forming crystals. So it starts crystallizing at this point of time, right, when the uric acid levels are more than 6.8 milligrams per deciliter. That is why this can be considered as a cutoff. Clear? So this can also be asked as an MCQ. So remember this point in mind. Okay. So now we know when do we call it as hyperuricemia, and some basics we have already understood about the purine metabolism. Now let us talk about the causes for hyperuricemia, right? What are the causes for hyperuricemia? We know the causes for hyperuricemia can be classified into primary and secondary. Now, if you open different textbooks, you will find different approaches for this classification. We really don't need to bother. The one that I'm talking about is based on the CMDT 2022 classification, like the 2022 CMDT edition, the classification that he is following. Because if you get into some other books, the classification might be slightly changed. But I particularly like this approach, so I'm talking about it. So we classify the causes for hyperuricemia into primary and secondary. In both these cases, there are two possible broad headings. In the sense, uric acid level is increased in these patients. So what are the possible causes? Either there is increased uric acid production or decreased uric acid elimination, right? So both these causes can be further subgrouped into conditions where there is increased uric acid production, right, and where there is decreased uric acid elimination or excretion, right? So for secondary also, let us just classify into increased uric acid production and decreased uric acid elimination. Okay. Now I said I like this CMDT classification, which is less confusing. The reason for that is it is very simplistic. So when we talk about primary and secondary, what is the difference? So in case of primary, even if you're talking about increased uric acid production, right? Primary increased uric acid production. The increased uric acid production here is primarily because of the abnormalities in the purine metabolism directly, in the sense the components of this metabolic pathway, the enzymes involved, the abnormalities at that level. Right. Now, if the purine metabolism is increased or there is a purine catabolism, the causes could be because of increased cell turnover or anything else. Right. In those cases, we will put them under secondary causes. Right. So primary means the purine metabolism is abnormal and there is increased purine turnover because of enzyme deficiencies. Right. So there is an inborn error of metabolism when we talk about primary. Okay. Then when we talk about primary conditions where there is decreased uric acid elimination, what is the mechanism or how do you differentiate between secondary causes for decreased uric acid elimination and primary causes? So secondary causes for uric acid elimination means the disorders of kidney. So at the level of kidney, something is either the kidney disease or some drugs or something is obstructing the elimination of uric acid. Then we will call it as secondary causes for decreased uric acid elimination, right? In case of primary, it remains idiopathic. It remains idiopathic. There is no renal disease. So you have normal kidneys. At least to start with, you have normal kidneys. So once there is uric acid crystals deposited, you can have abnormal kidneys. But to start with, you have normal kidneys. But idiopathic reasons, there is decreased uric acid elimination, right? Okay. So what are the important causes for uric acid increased production? Primary causes, we're talking about inborn errors of metabolism. So that means we have to talk about increased PRPP synthetase enzyme activity, right? Synthetase enzyme activity. That is one, right? The second thing we spoke about was decreased HGPRTase activity. Decreased HGPRTase activity. Now, this decreased HGPRTase activity can be complete or it can be partial, right? The other classification systems we were talking about, the complete is considered in secondary and the partial is considered in primary, but I did not really understand the logic behind that. That's why I'm not talking about it, right? So when it is complete is what we recognize as Lesch-Nyhan syndrome, right? Lesch-Nyhan syndrome. So this Lesch-Nyhan syndrome patients, we typically recognize it as a cause for self-mutilation, right? Self-mutilation. Okay, anyway, that is secondary. Right now, talking about the topic, yeah, this is the condition where patients are at increased risk of gouty arthritis, then urate nephropathy. But apart from this, right, apart from all this, patients with Lesch-Nyhan syndrome are also at increased risk of having neurological deficits. They can have neurological deficits and particularly intellectual compromise, right? Now, we have to also recognize that the gout and other related manifestations are definitely because of increased uric acid. But in Lesch-Nyhan syndrome, the neurological manifestations are nothing to do with uric acid levels. So if you treat this hyperuricemia, the gout and other manifestations might improve, but the neurological improvement is not known to occur. Okay, that is typical of our Lesch-Nyhan syndrome. Okay, then when it is partial, right? When it is partial, it is usually associated with gout without neurological manifestations, right? We have to recognize this, without neurological manifestations. Okay, now what are the causes for primary cause for decreased uric acid elimination? As I've already told you, it is idiopathic, right? If you have a kidney disease identified as a cause for decreased uric acid elimination, as well you will call it as secondary, right? Okay, now coming to the secondary causes. If you talk about increased uric acid production, the first thing is increased cell turnover, right? Increased cell turnover, that means increased DNA, RNA, ATP, GTP metabolism, and more like purine catabolism is going to occur. Increased cell turnover. And when we talk about decreased uric acid elimination, right, kidney disease becomes an important thing, and some drugs are something that I particularly want you to remember. So here is a table that, if you remember, I think that should be kind of adequate. This is a table from CMDT again, right? So primary hyperuricemia, increased uric acid production, right? That is typical of inborn errors of metabolism, enzyme defects. Lesch-Nyhan syndrome, that is HGPRTase, right? And your certain glycogen storage disorders also, like particularly Van-Jerkes is a risk factor. Van-Jerkes is also associated with increased purine catabolism. Okay, then decreased renal clearance, as I've already told you, that is idiopathic whenever we're talking about primary. Now talking about the secondary, increased catabolism or turnover of purine, that can occur in conditions where there is increased cell turnover, like myeloproliferative disorders, malignancies, especially disseminated or metastatic malignancies. Then chronic hemolytic anemia, again increased cell turnover. Cytotoxic drugs causing cell lysis, increased cell turnover. Psoriasis, where there is rapid cell turnover. We recognize psoriasis as an important risk factor for gout, right? And then decreased renal clearance of uric acid. So we're talking about secondary, so that means we're talking about abnormal kidneys or abnormal kidney function, right? So CKD should be first in the list. Then it could be drug induced. So when we talk about drug induced, thiazides, then low dose aspirin. Yeah, this is one point I particularly want you to pay attention. Low dose aspirin is recognized as a risk factor for gout or hyperuricemia, right? So whenever patients present with acute gout, generally we talk about management of acute gout with NSAIDs, right? But we cannot use two agents. One is paracetamol because it doesn't have anti-inflammatory property, and the second is aspirin because aspirin itself can cause hyperuricemia, right? Okay, then cyclosporine and niacin, and another drug I want you to remember is pyrazinamide. Pyrazinamide is also known to cause hyperuricemia. Okay, then diabetic ketoacidosis and starvation is recognized as a risk. Also, consumption of high fructose corn syrup is considered as a risk. It can cause hyperuricemia. Hypothyroidism, then hyperlactic acidemia, diabetes insipidus, Bartter syndrome, sarcoidosis, and lead poisoning. These are all conditions where there is decreased clearance of uric acid. Now, this lead poisoning, when it causes gout, we call it as Saturnine gout, which can also be asked as an MCQ. I think it was asked in 2021. Yeah, Saturnine gout, right? Saturnine gout is seen in which of the following conditions? A simple MCQ was asked in last minute assessment. So that is in lead poisoning, right? So this is the classification of causes for hyperuricemia. Now, having understood this, let us talk about what we call as gout. Now, what we know about gout? Gout is a condition where patients present with either monoarthritis. Typically, when I'm talking about acute gout, the patient presents with monoarthritis or oligoarthritis presentation, right? So we are talking about an inflammatory arthritis. So that means inflammation has to be triggered by deposition of the crystals. So deposition of monosodium urate crystals triggers what we call as inflammasomal pathway. Inflammasomal pathway. Now this pathway particularly includes some important cytokines. The most important cytokine is interleukin 1 beta, right? Interleukin 1 beta is a very potent inflammatory molecule. Now, where else we have spoken about this inflammatory molecule or inflammasomal pathway? We have spoken about inflammasomal pathway when we were discussing about periodic fever syndromes and autoinflammatory syndromes, right? Okay, so here in case of periodic fever syndromes, the mutations are responsible for activation of this pathway. In case of the gout, it is the presence of monosodium urate crystals are responsible for activation of this pathway. Now, this pathway activation includes our innate immune system, right? So that means we're talking about involvement of neutrophils and macrophages. Neutrophils and macrophages. Okay, particularly why I'm talking about this is neutrophil recruitment to the synovium is very important step in pathogenesis of the inflammation that we see in gout. Okay, so when we try to treat acute gout using colchicine, right? We treat them with colchicine. The colchicine actually inhibits neutrophil recruitment to the site where the monosodium urate crystals are being deposited. Clear? Okay. So gout presentation can be in three forms, right? So it can be in asymptomatic form. In other words, basically patient is hyperuricemic, right? Or it can be in the form of acute gouty arthritis, or it can be in the form of chronic gouty arthritis, or what we also call as chronic tophaceous gout, right? Where there is formation of nodules called as tophi, chronic tophaceous gout. Clear? Okay. Now talking about this acute gouty arthritis. Acute gouty arthritis is where patients usually present with. The most common presentation is in the form of monoarthritis, right? Sudden onset monoarthritis associated with excruciating pain. The pain is extremely excruciating. Like this is one of the worst pains that human beings can experience apart from subarachnoid hemorrhage and maybe parturition. This is also one of the very severe pain that patients experience. Excruciating pain. What is the most commonly involved joint? The most commonly involved joint is our first metatarsophalangeal joint. That means your great toe first metatarsophalangeal joint. That is the most commonly involved joint. Often at the time of presentation, joints are swollen and they are erythematous and they are very painful to touch. And because of the pain and swelling, patients have difficulty also in walking. That is the usual presentation. Clear? So the most common presentation of acute gout is in the form of involvement of first metatarsophalangeal joint. What other joints can be involved? Apart from this, your ankle joint and midfoot joint. Ankle joint and other midfoot joints are most frequently involved. Okay. Rarely ever there can be involvement of knee joint. That's rare. And if you talk about upper limb involvement, mostly it is the wrist joint. Yeah, in elderly, what we call as late onset gout or late presentation of gout, yeah, their patients can present with the involvement of small joints of the hand, but that is rare, right? Clear? So this is the usual presentation of acute gout. So in this image, you can see this acute gout. You can see the first metatarsophalangeal joint, swollen, red, right? There is erythema. There is swelling is something that we can appreciate. Erythema we can appreciate, right? And first metatarsophalangeal joint is what we can appreciate. Okay, clear? Okay, now this is particularly important because sometimes patients with pseudogout is nothing but a calcium pyrophosphate deposition disease presenting in acute form. That also can present in chronic form resembling osteoarthritis. That can also present in acute form resembling gout. So when it is resembling gout, right, when it is presenting as an acute, we call it as pseudogout. But there the most commonly involved joint is usually knee joint, right? That accounts for more than 50% of the patients with pseudo gout. Clear? So here it is MTP. As I've already told you, knee joint involvement is less common in comparison to involvement of MTP, ankle and midfoot joints, right? Okay, now talking about the second form of gout presentation, that is chronic tophaceous gout, right? So the chronic tophaceous gout is where patients present with deposition of the urate crystals on the joints, leading to formation of what we call as nodules, right? Nodules known as tophi. This is a second form. Okay. Apart from these, patients can present with involvement of kidneys. So the renal involvement can be in the form of, as we have already discussed, urate nephropathy, right? So urate nephropathy means it is interstitial deposition of monosodium urate crystals. So it's a interstitial kidney disease. Then there is also increased risk of formation of uric acid stones. Uric acid stones, right? So these are the usual ways of presentation of patients with gout. Now, having understood this, let us talk about the diagnosis of gout. Okay. Now, for the diagnosis, first thing we have to understand is basic epidemiology. So we have already understood the presentation. We should know that males are more frequently affected than females, and the usual age of presentation of gout is 40 plus. So 40 to 60 years is the usual age of presentation of patients with gout. Why am I talking about this? Because when we talk about pseudo gout, right, mostly, particularly when we generally say CPPD disease, it mostly patients are 60 plus at the time of presentation, right? And there females are slightly more affected than males, particularly the osteoarthritis, pseudo osteoarthritis variant. Females are more affected than males when we talk about pseudo gout. Clear? Okay. Now, how do we diagnose these patients? If they present with the classical acute gout, it is not usually mistaken because patients have this grade 2 involvement, which is very, very characteristic. The joint is swollen, tender, patient is like literally crying in pain, and the presentation is very, very characteristic. Okay, but when we talk about chronic tophaceous gout, yes, you might have confusion, particularly when it mimics like rheumatoid arthritis. We might have confusion because these tophi might resemble rheumatoid nodules. So sometimes there may be confusion. So we have to think of a definitive diagnostic strategy, right? So can uric acid be a definitive diagnostic strategy? Well, it has a good negative predictive value. It doesn't have a great positive predictive value, but it has a good negative predictive value, particularly when we're talking about acute gout. Because as we know, in case where patient presents with acute gout, uric acid levels can be normal, right? Uric acid levels can be normal or even decreased to some extent, right? So serum uric acid levels in most patients with chronic gout will be increased, but they can be normal in patients with acute gout. So it has a low utility when we talk about acute gout presentation, right? Okay, so serum uric acid levels will be usually increased. Okay, now the second thing we can do is we can do a synovial fluid analysis. Now we have to recognize that patients with gout, particularly acute gouty arthritis, are having inflammatory arthritis. We have already discussed about the inflammasomal pathway involved in triggering the inflammatory arthritis. So when we talk about inflammatory arthritis, there is inflammatory arthritis. So when we talk about inflammatory arthritis, we recognize some basic points, right? Particularly gout is a classical example of acute inflammatory arthritis where all the characteristic findings of inflammatory arthritis are present. The swollen joint, red, tender joint, all those are present, right? And when we do the synovial fluid analysis, we will see the evidence of inflammatory arthritis. That means we are talking about WBC count, which is usually more than 2000, right? Often we see WBC count 20K plus, and that sometimes confuses, particularly when little larger joint is involved. Like if it is a patient with acute gout having knee involvement or ankle involvement, sometimes it might confuse us with septic arthritis because the WBC count is staggeringly elevated, right? That is one thing we can do. And the second thing we can do is what is considered as a gold standard for the diagnosis of gout. That is the synovial fluid analysis. We can try to see the monosodium urate crystals. So for this, for the identification of monosodium urate crystals, we have to do the polarized microscopy, and under that these monosodium urate crystals show negative birefringence. Negative birefringence. Okay, so that means we are basically giving the polarized light and we are trying to see the crystals, and we have an analyzer parallel there, right? So when there is a parallel analyzer and there are crystal molecules present and light hits the crystal molecules at 90 degrees. If it is showing positive birefringence, it usually achieves a blue color, and if it is showing negative birefringence, it achieves yellow color. So here we will be seeing yellow colored crystals, right? So we will be seeing yellow colored crystals because it is showing negative birefringence, and these crystals are usually needle shaped, right? The shape of crystals is very important. These crystals are usually needle shaped. Why is it important? Because one of the important differential for us sometimes would be pseudo gout. So in patients with pseudo gout, it shows positive birefringence. So pseudo gout shows positive birefringence. So that means it will be, instead of yellow, it will be blue in color. The crystals will be blue in color. The second thing we will notice is the shape of the needle. So the shape of the crystals will be needle shaped in case of gout, but these crystals will be rhomboid shaped in case of pseudo gout, right? So in case of pseudo gout, this will be rhomboid shape. So this is a very, very important tool for the diagnosis, and this we right now recognize as the gold standard, right? So documentation or demonstration of these crystals is considered as the gold standard for diagnosis of any crystal deposition disease per se. You talk about CPPD, you talk about other crystal deposition disease, you talk about gout, this is the gold standard. So if you can demonstrate the crystals in the synovial fluid, that can be considered as the gold standard. Clear? Okay. Apart from that, yes, imaging itself may be able to give you some particular clues. So we can use ultrasound for diagnosis of gout. We can also use X-ray, and both of these are important image based questions. So on the ultrasound, we notice something called as double contour sign, which is also used in the classification criteria for gout in the ACR classification criteria 2015, right? So on the ultrasound, what are we seeing? We are seeing something called as double contour sign. Double contour sign. I'll talk about it when we see the image. Just right now, remember, we talk about double contour sign. And on the X-ray, particularly, we see something called as Martel sign. Martel sign, right? We have to learn both these, Martel sign as well as double contour sign. Okay. So imaging and your USG has some utility when it comes to diagnosis of gout, right? Done? Okay. Now, before we move on to see those images, we have to also understand the 2015 ACR ULR classification criteria for gout. Okay, so the criteria includes three domains. One is clinical domain, the laboratory domain, and imaging domain, right? So the maximum total score on this scoring system is 23, and when patients have more than or equal to 8, we can classify the case as gout. Okay, is that clear? Okay, now let us talk about the clinical domain. So clinical domain looks into pattern of joint or bursa involvement. Then it also looks about the characteristics of episodes of arthritis whenever they occur, right? So typically gout is monoarthritis, and the episodes, whether it is oligo mono, and what are the characteristics of those arthritic episodes is the second component. Then time course of the episodes, whether there was one typical episode or whether patient was going through recurrent typical episodes, and then the clinical evidence of tophus, whether the tophi are present or not, right? So first let us address this pattern of joint or bursa involvement, right? As I've already told you, the most common site is MTP involvement, first MTP involvement, that is characteristic. So if there is first MTP involvement as part of monoarthritis or as part of oligoarthritis, right? In that case, we are giving a substantial score to the patient on the clinical domain, right? Or if there is involvement of ankle or midfoot as part of monoarthritis or as part of oligoarthritis. Monoarthritis, only that joint is involved, or as part of oligoarthritis. In that case, we give a score of 1, right? If there is knee, hip or any other joint involved, we give a score of 0. We give a score of 0. Clear? Okay. So this first talks about the typical joint involvement. Then the next thing is the joints that are involved, their characteristics. So when we were discussing about the joint involvement, we spoke about 3 things. The first thing we spoke about is presence of erythema on the joint surface, right? So if there is erythema present, that is characteristic of an inflammatory arthritis, and acute inflammatory arthritis with erythema, I think the first thing that should come to mind is gout, right? Okay, erythema. Then the second thing is pain, like the site is tender enough so that patient is not allowing to touch the site, or the touch triggers or worsens pain. Okay. Then the third thing is the tenderness, pain, and the joint swelling is restricting patient from walking or mobility. If it is the upper limb joints, maybe the movement of joint is affected. If it is the lower limb joint, walking is affected, right? So there is a restriction of walking. Mostly lower limb joint only affected, so mostly patients will be presenting with severe pain, and the pain is restricting them from walking. If all these three characteristics are present, then we will be giving them 3 points. If two characteristics are present, 2 points, and if one characteristic is present, 1 point, right? Okay. Now, if the patient is having one typical episode, 1 point. If patient had history of recurrent typical gouty episodes, then 2 points. Okay. And if the tophi are present, right? Tophi has a much more utility in terms of diagnosis in comparison to the one presentation of monoarthritis, right? So if there are tophi present, then patient gets 4 points, right? Okay. Then we are looking at serum uric acid levels. So serum uric acid levels more than 10, we give the highest point, that is 4 points. 8 to 10, 3 points. 6 to 8, 2 points. Okay, that is the lab domain. Now talking about the imaging domain, as we have already understood, we can look at most likely ultrasound, or we can do the X-ray. So if on the ultrasound, if the double contour sign is present, we are giving 4 points. And if on the X-ray there is typical gouty erosion, what we call as Martel sign, then we will be giving 4 points to the patient. So total possible points is 23, more than or equal to 8 points. That is sufficient enough to classify the case as gout. But we have to also note, as I've already told you, uric acid levels have much more of a negative predictive value in comparison to positive predictive value. So if the serum uric acid levels is less than 4, we are having a minus 4 points, right? Minus 4 points. And if you have done the synovial fluid analysis and monosodium urate crystals are negative, we are giving minus 2 points. So patient might have accrued 10, 12 points, but if the serum uric acid level is less than 4, then we will be giving minus 4 points. Similarly, patient might have accrued whatever number of points, but if the synovial fluid does not show monosodium urate crystals, then we will be subtracting 2 points, and then we are deciding whether to classify the case as gout or not, based on whether the patient has accrued finally a score of more than or equal to 8 or not, right? Okay, so this is the 2015 ACR EULAR gout classification criteria. Okay, now let us go through the important images. So now we know how we classify case based on the classification criteria, and how we make a clinical judgment when we have the patient, when we have acute gout patient, when we have a tophaceous gout patient. Now let us look at the images. So the first image we are talking about is typically seen in patients with gout, right? This is not seen in patients with pseudo gout. So this imaging finding is a imaging of ultrasound of the affected joint, and this helps us to identify a case of gout and differentiate it from a case of pseudo gout. So what are we seeing here? We are seeing double contour. Okay, so the double contour is formed by, this is the bone, right? And this is the joint cartilage. This is the joint space. This is the joint space. This is the joint cartilage, right? So all the black we are seeing is the joint cartilage. So this is the joint cartilage, and this is the subchondral bone, the bone just beneath the joint cartilage, right? So here we are seeing the subchondral bone. This is our joint cartilage. Now what happens in patients with gout is there is increased monosodium urate crystals in the joint space, and these urate crystals get deposited on the outer surface of joint cartilage. So we are seeing one hyperintense or hyperechoic zone here, the blue line that I am drawing. That is the subchondral bone, right? The periosteum of the bone definitely is echogenic, right? So this is the periosteum of the bone. Now what we are seeing, the one that I have driven in yellow, right? This is the outer surface of, joint cartilage, right? Joint cartilage, where there is deposition of monosodium urate crystals. So the joint fluid, synovial fluid, is rich in monosodium urate crystals, so they get deposited on the outer surface, the surface of the joint cartilage, which is facing the cavity, right? There is deposition of these monosodium urate crystals, and that gives rise to this hyperechogenic zone, right? So we are seeing this typical double contour sign. This is typical of gout. We don't see double contour sign in pseudo gout. In pseudo gout, the calcium pyrophosphate crystals are deposited inside the cartilage, not on the surface, right? Here they are deposited on the surface. So in pseudo gout, they are deposited inside the cartilage. So this is where we will be seeing the deposition. Deposition can be often in the form of punctate deposition. It can be linear deposition or punctate when we talk about pseudogout. So you will see a line of calcification here, or a string of pearls like deposition of calcium here in case of pseudogout. So ultrasound is a useful tool for differentiation between gout and pseudogout. True? Okay. So these are the real ultrasound images where you can clearly appreciate this double contour sign, right? So the periosteum of the bone here giving rise to one hyperechogenic zone. The second hyperintense zone is because of the calcification, or because of the deposition of monosodium urate crystal on the outer surface of the cartilage, joint cartilage, and this black area is the cartilage, the thickness of the cartilage. One more image, two contours here. One more image, two contours here. This is typical of gout, right? Okay. Now let us look at this next image. Just give me a second. Yeah. So in this image, what we appreciate here is this is the subchondral bone, right? So just let me write it here. This is the subchondral bone. This is our joint cartilage. Can you appreciate? This is our joint cartilage. This is the outer surface of the joint cartilage, and inside the joint cartilage, right, within the material of the joint cartilage, you can see linear deposition of calcium, right? Linear deposition of calcium pyrophosphate crystal. So this is very typical of, this image is very typical of pseudogout, right? Pseudogout. Clear? Okay. Now let us look at the next image. This is an X-ray of a foot. So first thing we notice is the abnormalities that we are seeing are affecting the first metatarsophalangeal joint, right? This is the first thing that becomes evident here. Okay. You can appreciate this soft tissue swelling. This is a typical tophi, right? So we can appreciate a soft tissue swelling here, and this is the typical tophi, right? So this is our tophus, one tophus. Okay. Now this tophus, the tophus is not formed inside the joint space. It is outside the joint space, right? So it will cause erosion of the bone, right? So you can appreciate the joint line is intact here, but there is erosion of the bone because of the deposition of the monosodium urate crystals in the subcutaneous, in the soft tissue spaces, not in the joint space, right? So now this erosion occurs in such a way that there is lytic lesion of the bone, right? You can appreciate there is bone loss here, but this bone loss is associated with, you can appreciate here, overhanging edges, right? So there is bone loss, but the bone loss is associated with overhanging edges, right? So sometimes it looks like, just give me a second, sometimes it looks like a G. So this is also known as G sign, right? This is sometimes known as G sign. So what we see here is also known as G sign, right? Known as G sign. This is also known as Martel sign. Martel sign. This is also known as rat bite erosion. Rat bite erosions, right? All of these mean the same thing. G sign, Martel sign, or rat bite erosion mean the same thing, right? So there is bony erosion or lysis with overhanging edges. This is a particular word to note. Overhanging edges. Overhanging bony edges. This is what we call as Martel sign. This is typically seen in patients with gout. Clear? This is typically seen in patients with gout. So if you have Martel sign, that can be a contributor in your ACR-Euler classification criteria. If you have double contour sign like here, that can also be scored in our ACR-Euler classification criteria, right? Okay. Now that is about the diagnostic approach. Now coming to the management, like once we have diagnosed or classified a case as gout, how do we manage those patients, right? First, let us talk about management of acute gout, right? Management of acute gout. Now acute gout, the uric acid lowering therapy is not particularly important. So now the monosodium urate crystals have actually activated an inflammasomal cascade. So we have to stop the inflammation. So patient is bothered by pain not because of his uric acid levels, right? So if there is a question asking you what is the drug of choice for management of acute gout, the first drug of choice or the first line agent is usually NSAIDs. Because these patients have severe excruciating pain, a low-grade NSAIDs may not be very effective, right? So we have to use potent NSAIDs. So what are the potent NSAIDs we can use? We can think of using indomethacin or ibuprofen or naproxen. Particularly, I have always used naproxen and patients did respond well when we used naproxen, right? NSAIDs. What can't be used? We cannot use aspirin, as we have already discussed. Low dose aspirin is a known factor for causing hyperuricemia, one of the important drug to cause hyperuricemia. Then we cannot use paracetamol because paracetamol is not an anti-inflammatory substance. So here the pain is because of the inflammation, not merely because of the mass effect or compression or something like that. In that case, maybe paracetamol may be to some extent helpful, but there is a severe intense inflammation, and until and unless you control inflammation, the pain is not going to come down. So in that case, your paracetamol is not useful, aspirin is not useful. Now, if the patients are not getting relieved by NSAIDs, as a second line agent, we can think of using colchicine, right? We can think of using colchicine. Okay, now colchicine is usually used initially. First loading is 1.2 milligrams. This is what we give as the loading dose. After that, 1 hour later, we give them 0.6 milligrams. Okay, after that, we switch over to 0.6 milligrams BD till there is resolution of inflammatory arthritis, right? Now, I have already discussed how colchicine helps. Colchicine helps by preventing the recruitment of neutrophils to the synovium, right? That is the mechanism of action of colchicine. We should also be aware about the side effects of colchicine, because colchicine is not well tolerated by most of the patients. So what is the side effect it can cause? It can cause intractable diarrhea, or very severe diarrhea, and patients often find it difficult to tolerate it. Intractable diarrhea is one thing I want you to particularly remember as a side effect of colchicine. Okay, apart from these, what else can we use? Okay, now we were talking about inflazomal pathway, so that means there is role of interleukin 1. So interleukin 1 blockade can also be used for treatment of your acute gout, but the use of those drugs is restricted to conditions where NSAIDs and colchicine have failed. Particularly, you have an experience that the first episode you were not able to handle with NSAIDs and colchicine. Colchicine failed and you were eventually forced to use IL-1 blockade. So subsequent episodes, you know that the IL-1 blockade may be very important contributor. So you might have to think of giving them IL-1 blockade, right? So IL-1 blockade can be a strategy. Now, what are the drugs that can be used IL-1 blockade? We can think of using anakinra, but mostly we end up using canakinumab. Anakinra can be used, but mostly we end up using canakinumab. This is the latest drug, more effective than anakinra, right? Clear. So this is the acute management of gout. Now comes the question, should we try to give them uric acid lowering therapy after they recover from the acute gout? Yes, definitely during the acute gout, we don't use uric acid lowering therapy, but after they made a recovery, can we use? Okay, the consideration depends on various factors. So if the patient with acute gout had manifestations of hyperuricemia elsewhere, like they have hypertension, right? If they have hypertension, yes, you can think of treating them. Or if they have other manifestations of hyperuricemia, you can treat them, right? Or in other words, if patients only have gout as a presenting feature and there is no evidence of other manifestation of hyperuricemia, then a single episode does not call for uric acid lowering therapy. So usually when patients present with more than 2 to 3 episodes, then we think of starting them on the uric acid lowering therapy. Clear? Okay. Now, once the patient presents with chronic tophaceous gout, chronic tophaceous gout or other manifestations of hyperuricemia, like there is hyperuricemic renal injury, hyperuricemia. In that case, what are the treatment approaches, right? So just let me put a slide. Okay, so if patient is presenting with chronic tophaceous gout, or there are indications for initiation of treatment in patients with hyperuricemia. In these circumstances, what are our options? Our options include, one thing we can try to do is increased uric acid elimination, right? We can increase the uric acid elimination, or the second thing we can do is decreased uric acid production, right? So for decreasing the uric acid production, what is our target? So when we are talking about chronic tophaceous gout or hyperuricemia, we are basically talking about persistent decrease in uric acid level, trying to maintain the uric acid levels within the target. The prescribed target of uric acid levels is usually less than 6 milligrams per deciliter. Why? Because 6.8 is associated with crystal formation, right? Okay, so what are the options that we can follow for decreasing the uric acid production? So there is only one enzyme that we can target, that is xanthine oxidase, right? If you remember from the previous slide, we were talking about xanthine oxidase converting the xanthine to uric acid, right? So the xanthin was the penultimate molecule before it becomes uric acid, and that conversion is done by uric acid, xanthin oxidase. So if we inhibit xanthin oxidase, xanthin will accumulate, which is less toxic, and uric acid levels will steeply decrease, right? So xanthin oxidase inhibitors are the class of drugs that can be used for prevention of uric acid production. So what are the drugs we know? Allopurinol is a classical example. Allopurinol is the classical example, and this is the drug of choice. This is the first line agent, the drug of choice whenever we talk about regular management of gout, right? Whenever we talk about the management of hyperuricemia, this is the drug of choice. Alternatively, we have also another drug called as febuxostat, which is also a xanthin oxidase inhibitor. Now, allopurinol is considered as the first drug of choice, but in certain circumstances, you might have to consider febuxostat, particularly if the patient is hypersensitive to allopurinol. Allopurinol being a purine derivative, some patients can be hypersensitive. In that case, we might have to use febuxostat. And the other circumstance where we might have to use febuxostat is patients with renal impairment, right? So it is safe in renal impairment. Our febuxostat is safe in renal impairment, so we can use in patients with renal impairment, right? Clear? Okay, now coming to options where we can think of increased uric acid elimination. So the drugs which are used for this purpose are called as uricosuric agents. Uricosuric agents, right? We call them as uricosuric agents. What are the examples? We all know probenecid as an example from our second year pharmacology itself, right? Probenecid as an example. Then we also have another new drug called as lesinurad. Lesinurad is a new drug which can be used for treatment of hyperuricemia, right? These are the true uricosuric agents. Particularly, I want you to remember this is an MCQ which has been asked multiple times. That is, which of the following antihypertensive has uricosuric properties? That is losartan. Losartan has uricosuric properties. It can increase uric acid elimination in kidney, right? So this is a MCQ which has been asked multiple times. So please be aware about it. So particularly you are having a patient with hyperuricemia and hypertension, then in such cases you can choose, like when currently guidelines say when you talk about hypertension, the guidelines say we should be using a combination of dihydropyridine calcium channel blockers like amlodipine plus a AC inhibitor or ARB. So in that case, consciously you can choose losartan because it has a uricosuric properties, right? Remember this point particularly because this has appeared 5 times as an MCQ since the first edition of NEET 2017. On different papers, this has appeared multiple times, and this has also appeared as an MCQ when they used to conduct this DNB medicine exam in the form of MCQ. The one paper used to be MCQ based, so there also they used to ask this losartan as a uricosuric drug frequently, right? So this is one point I want your attention. Now, apart from these, we have also developed, because we were talking about this conversion of uric acid to allantoin, right, by an enzyme called as uricase. So it is not existing in humans, but we have synthesized it. So we have 2 uricase analogs, right? So one is our rasburicase, which is a recombinant uricase which is based on bird. So B here stands for actually bird. So we have identified the sequences of the uricase enzyme in birds, and we have synthesized with a recombinant technology. So this is what we call as rasburicase. As I've already told you, the problem with rasburicase is it's a short acting, right? It's short acting, so not very practically useful. So we mostly use it in patients with tumor lysis syndrome where we need to treat the patient for a short period of time, right? But we have also developed a new drug called pegloticase, which is a long acting, right? Which is long acting because it is coupled with this uricase is coupled with polyethylene glycol molecule, so it becomes long acting. So it can be used for treatment of chronic gout or hyperuricemic conditions. Clear? Okay, so this is the pharmacological management of gout. So that completes our discussion on the gout. So now let us move on to discuss about pseudo gout, or what we also call as calcium pyrophosphate deposition disease. Now traditionally when we talk about CPPD disease, we talk about pseudo gout, but pseudo gout is not the entire spectrum of CPPD disease. So today we recognize patients with calcium pyrophosphate deposition presenting in various formats, right? So pseudo gout is not the only presentation. So what are the presentations we know? Okay, the first thing we have to understand is this calcium pyrophosphate deposition is part and parcel of aging process. So when you talk about patients who are 60-70 years old, most of them will have calcium pyrophosphate deposition. Okay, whether it is associated with inflammatory changes, whether it is associated with the erosive changes or not. That decides whether you call it as a disease or not, right? So CPPD deposition can occur with the process of aging. Okay. Now, clinically relevant manifestations are these patients sometimes can present with. Okay, first point is osteoarthritis is associated with CPPD deposition. Okay, so in that case, the CPPD deposition is secondary to osteoarthritis and it is not a primary disease, right? So as I've already told you, aging and CPPD deposition, they are like going hand in hand, right? So in that case, it is not a primary disease. So there we treat that case as a typical case of osteoarthritis, nothing more than that. Okay, but some of these patients can present in the form of acute mono or oligoarthritis, which is usually inflammatory. Now, when we talk about osteoarthritis, as such, it is a non-inflammatory condition. Only thing is osteoarthritis started and then there is CPPD deposition, right? But when we talk about acute mono or oligoarthritis due to CPPD deposition, we are talking about an inflammatory arthritis. This is usually inflammatory arthritis. So for all practical purpose, this might resemble like gout. That is why this entity is in the past used to be called as pseudo gout, right? It used to be called as pseudo gout, acute mono or oligoarthritis due to CPPD crystal deposition, inflammatory arthritis, right? So inflammatory arthritis means if you do a joint synovial fluid aspiration, it will show WBCs more than 2000, often significantly higher, right? Okay, so that is one point. Now, how does it differ from our gout? The most commonly involved joint here is usually what? It is knee joint, not our first MTP or ankle or midfoot joints, right? It is usually the knee joint which is most commonly affected, right? And if you do the synovial fluid study in patients who presented with such picture, it will definitely show WBC count which is more than 2K because this is also an inflammatory arthritis, but it will show CPPD crystals, calcium pyrophosphate crystals, which are, as we have already discussed, these are usually weakly, yeah, not fully or strongly positive, but they are positive birefringent, weakly positive birefringent crystals. So that means these will have, when the crystals are present in parallel to the analyzer, these will present in blue color and the crystals are usually rhomboid shaped, right? The crystals are usually rhomboid shaped. Okay, so this is one point that helps us to distinguish. And when we do ultrasound of the affected joint, right, we will see punctate calcification of the joint. Okay, this punctate calcification typically more commonly seen when we talk about a chronic CPPD deposition disease, but some of these patients might have an acute presentation. In that case, you will be seeing this punctate calcification of the what we call as the joint cartilage, right? So that is one point I wanted you to note. Now, the next kind of presentation could be what we call as osteoarthritis like. Okay, now here is a difference. So when I said osteoarthritis is associated with CPPD, the primary problem is patient has osteoarthritis, calcium pyrophosphate crystals go and get deposited in a joint which is osteoarthritic, right? But when we say osteoarthritis like, here the patient is presenting with degenerative joint changes. The degenerative joint changes are because of the crystal deposition. The crystal deposition is triggering the degeneration, right? The degeneration is not the primary event. It is the crystal deposition that is the primary event. So such patients we call it as pseudo osteoarthritis. Now this is a non-inflammatory condition, right? This is a non-inflammatory condition because it's a degenerative condition, right? So you will not see your the joint synovial fluid levels more than the WBC levels more than 2000. Then you will also not see this characteristic inflammatory arthritis findings like the morning stiffness. All those things will not be seen. Like morning stiffness, if it is present, it will be usually less than 30 minutes, right? That is what we call as osteoarthritis like presentation. Some of these patients can also present with what we call as pseudo rheumatoid arthritis. So in that case, we call it as pseudo RA presentation. So pseudo RA kind of presentation occurs where patients present with bilateral symmetrical hand joint arthritis, right? hand joint arthritis. So it clinically resembles rheumatoid arthritis. This is also an inflammatory arthritis. This is also an inflammatory arthritis. So for all practical purposes, it resembles rheumatoid arthritis. But then if the patient does not satisfy the rheumatoid arthritis classification criteria, and if at all you study their synovial fluid, you will be able to identify CPPD crystal deposition. Some of the patients may be RA factor positive, but anti-CCP positivity is quite rare. Anti-CCP is usually not positive, right? So this is the entire spectrum of CPPD deposition disease. Okay, so how do we diagnose? Obviously, we have to demonstrate that there is CPPD crystals deposited in the joints, and we all know, particularly when we talk about CPPD crystal deposition, we should be talking about osteoarthritis like or pseudo-rheumatoid arthritis like presentation. Pseudo-osteoarthritis or pseudo-rheumatoid arthritis. If you do the USG of the joint, you will have this punctate calcification of the joint cartilage. Punctate calcification of joint cartilage, what we also call as chondrocalcinosis, right? Chondrocalcinosis. Now, chondrocalcinosis may also be seen in osteoarthritis with CPPD deposition, because the deposition occurs in the joint cartilage, right? Okay, so this is the image that we had already seen. I think you can appreciate this linear or punctate calcium deposition within the joint cartilage, right? This is very typical of CPPD deposition disease, right? Okay, now how do we treat these patients? Well, because CPPD deposition is part and parcel of aging, probably when they present with OA-like or pseudo-RA kind of picture, pseudo-OA or pseudo-RA kind of picture, we can't do much about this, right? So we can only try to manage these patients symptomatically. But if they present with this pseudo-gout kind of picture, right, these patients can be helped by colchicine, because there is intense inflammatory activity happening here also. These patients can be helped by colchicine. And you might also try IL-1 blockade, but mostly colchicine suffices in most cases, right? Okay, so what are the differences we have learned between our CPPD deposition disease and our gout, or in other words, gout and pseudo-gout? So gout and pseudo-gout both are inflammatory joint disorders. Both are often presenting in monoarthritis. Gout, the most commonly affected joint is first metatarsophalangeal joint. Pseudo-gout, the most commonly affected joint is knee joint, right? Both show crystals, but the gout crystals, the monosodium urate crystals, are negatively birefringent and they are needle shaped. They glow in yellow color because they are negatively birefringent. But when we talk about the pseudo-gout, the crystals here are CPPD, the calcium pyrophosphate crystals, and they are positively birefringent. So they usually show up blue color. And the next thing is like blue color when the crystals are parallel to the analyzer and the crystals are rhomboid shaped, right? Okay. Now let us move to the next deposition disease that we are talking about, calcium hydroxyapatite deposition disease. So this calcium hydroxyapatite particularly gets deposited in the periarticular structures. Okay, so that is one kind of presentation, and sometimes it can get particularly deposited inside the joint space, causing this joint erosions, right? So there is only one important MCQ point I want you to remember. Joint erosions are usually rare, but they can occur. When they occur, the most commonly affected joint is our shoulder joint. Shoulder joint is the most commonly affected joint, right? So in that case, we call it as Milwaukee. In that case, we call it as Milwaukee shoulder. We call it as Milwaukee shoulder or Milwaukee disease, where there is erosive arthritis of the shoulder joint because of the deposition of calcium hydroxyapatite, right? Apatite crystals. So this is an image of Milwaukee shoulder, right? Milwaukee shoulder. This is an image of a patient with Milwaukee disease of the shoulder. Okay, so if the MCQ appears from this, it will be very simple. They will ask Milwaukee shoulder or Milwaukee disease of the shoulder is seen in which of the following conditions, right? That is your basic calcium phosphate or calcium apatite or calcium hydroxyapatite, all means the same thing, deposition disease, right? Okay. Now the last thing we are talking about is calcium oxalate deposition disease. So sometimes there can be calcium oxalate deposition. So when we spoke about hydroxyapatite, the joint The most commonly affected joint was the shoulder joint. When we talk about calcium oxalate deposition, most commonly affected joints are finger joints, small joints of the fingers, wrist joint, and elbow joint, right? So here, like in case of calcium hydroxyapatite, yeah, this is another point I wanted you to note, right? The crystals are usually non-birefringent, right? Non-birefringent. They are not birefringent. But the crystals in case of oxalate, calcium oxalate crystals are birefringent. They are strongly positively birefringent, and the shape. So when they are positively birefringent, the crystals will appear blue in color when the crystals are placed parallel to the analyzer, right? The light is hitting or at 90 degrees and the analyzer is parallel to the crystal. So in that case, it will appear blue in color, right? So the shape of the crystal depends on whether the crystals are the monohydrate oxalate crystals or dihydrate. If it is monohydrate, the shape of the crystal will be dumbbell shaped, and if it is dihydrate, they will be envelope shaped, right? So the dihydrate crystals will be envelope shaped, monohydrate crystals will be dumbbell shaped, right? So that's all we need to know about the crystal deposition arthropathies. So I hope we have covered all the key MCQ points that we need to know. Before I wind up, one key area I want you to focus on is difference between gout and pseudo gout, right?